Welcome back to The Explainer. I'm Harshal. Today, we're unpacking part 8 of our series to learn exactly why applying a skin substitute blindly onto an unprepared wound bed is now an immediate, automatic denial under the 2026 CMS policy shift. If you've been relying on old habits to get these high-cost therapies reimbursed, it's definitely time to recalibrate. Now, as we transition from Part 7's focus on basic debridement audits right into advanced cellular and tissue-based therapies, we have to address a massive elephant in the room. You must understand that high utilization and repeated placements of skin substitutes without prior conservative care have absolutely forced CMS to rigorously target your documentation. They are no longer just looking at the procedure code you selected. They're looking at the entire clinical story leading up to it. So why exactly is that unprepared wound an automatic denial? Well, here's the compliance gauntlet we're going to run today to figure that out. 1. The 2026 CMS paradigm shift. 2. The 3-step prerequisite pathway. 3. Navigating repeat applications. 4. A case study on a 72-year-old patient. And 5. The 3 golden compliance rules. All right, kicking things off with Section 1, the 2026 CMS paradigm shift. Product alone does not justify payment. Okay, let's really let that sink in because this right here, it's everything. This quote represents the new core standard of 2026. In the past, there was this misconception that simply using an expensive advanced product guaranteed reimbursement. Well, not anymore. CMS identified huge overuse, applications totally lacking prior standard care, and repeated placements with minimal progress. Because of all that, CMS now demands explicit proof of medical necessity, correct timing, and a documented healing response before they will reimburse for any skin substitute. Look at the stark contrast here. As gatekeepers of compliance, coding teams and clinicians alike really must realize that a perfectly selected CPT code matched with a weak documentation of clinical justification, that's an immediate denial. The old mindset was purely transactional. You do the procedure, you pick the code. That the 2026 mindset is clinical and outcome-driven. You have to prove the necessity and actually show the improvement. Moving right along to Section 2, the 3-step prerequisite pathway. So the crucial takeaway is that skin substitutes are an advanced therapy, meaning you simply cannot jump straight to them. This 3-step prerequisite pathway is an unbreakable clinical rule. First, you must document standard care, typically requiring 4 weeks of interventions like compression, offloading, or moist wound dressings. Second, you need adequate debridement and bed preparation, which means removing devitalized tissue to create a nice, clean, bleeding base. And finally, step 3 requires explicitly proving in your notes that healing has literally stalled and that the wound shows a documented lack of progress despite all your standard care. Whether you're using surgical, mechanical, enzymatic, autolytic, or biological debridement, the goal is always clearing the way for healthy tissue. Applying a costly skin substitute over a non-debrided or infected bed without clearing out that necrotic tissue is a massive red flag for Part B MAC auditors. CMS wants absolute proof that the wound was actually ready to receive this advanced therapy. Next up is Section 3, Navigating Repeat Applications. Listen, those routine weekly graft applications with copy-pasted progress notes, they're completely indefensible now. The days of auto-scheduling a patient every single week for a new graft application with a note that just says, wound healing, continue plan, are totally over. Auditors are actively hunting for these specific triggers to issue recoupments. If you skip documenting standard care failure, graft over necrotic tissue, clone your notes, or keep applying product without the wound actually shrinking in size, you're going to face audits. So how do we protect ourselves here? For every single repeat placement, you must explicitly record the specific product name, the precise size, the exact area covered, and most importantly, the objective healing response measured in centimeters across all encounters. You have to provide real justification for each session. You must show what actually changed. If the wound was 10 square centimeters last week and it's 10 square centimeters this week, you need a rock-solid clinical rationale for why an additional graft is medically necessary today. Let's ground all these rules in Section 4 with a real-world case study, a 72-year-old patient. Think about your typical diabetic or chronic ulcer patient. Our 72-year-old patient presents with an 8-week chronic left lower leg ulcer, initially measuring 5.0 by 4.0 by 0.3 centimeters. The wound is showing moderate drainage and persistent slough, and this is despite 4 full weeks of dedicated compression therapy, moist dressings, and infection control. This is the exact profile of a patient who has legitimately failed standard conservative care. Let's look at how this practically builds in your documentation. Notice how Encounter 1 flawlessly proves wound bed readiness. The provider doesn't just casually say they debrided, they meticulously document excisional debridement down to subcutaneous tissue, creating a clean, bleeding bed. Notice the measurements, too. The wound goes from 5.0 by 4.0 down to a precisely measured 4.8 by 3.8 centimeters after the margins are prepped. Only then, once the bed is truly ready, do they secure that 18 square centimeter graft. This tells the full compliant clinical story. Fast forward 2 weeks to the follow-up, Encounter 2. At this visit, the provider compliantly justifies a repeat application by proving objective progress. The notes detail that the area reduced from 4.8 by 3.8 down to 3.9 by 3.0 by 0.2 centimeters. They document the exact remaining wound size, note the increased healthy granulation, and even adjust the care plan based on reduced drainage. Because they proved this measurable progress with hard numbers, placing a second application is fully defensible. Now think about the alternative. If this clinician had simply slapped on a second graft without meticulously documenting that measurable size reduction and clinical rationale, they would have walked right into a negative scenario, resulting in a highly costly audit failure. Let this be your internal alarm system, folks. If you cannot objectively prove with numbers and clinical descriptors that the wound is getting better, stop and reassess before applying more expensive product. Let's wrap things up with Section 5, the 3 golden compliance rules. Here is your ultimate 2026 checklist. Rule number 1, ensure prerequisites are met by clearly documenting the failure of standard care. Rule number 2, validate medical necessity by tracking precise measurements over time to prove progress. And rule number 3, tell the full clinical story from wound preparation and debridement all the way to the patient's objective healing response. If your documentation hits these 3 marks, you transition from being just a biller to a true compliance gatekeeper. Make sure you join me for Part 9 of our series, where we'll dissect the top denial trends and high-risk compliance pitfalls that are currently catching clinics off guard. But before you go, I want to leave you with a crucial question to think about for 2026. When an auditor reads your chart tomorrow, will they see a clinician who merely documented a product, or will they see undeniable proof of a patient's healing journey? Until next time, keep your documentation sharp and always decode healthcare with Harshal.